Please welcome Dr. Lavie. Thank you for coming, Chip.
Thank you very much. Thank you very much for the hospitality and for the invitation to speak here. Everyone's been extremely nice through the process, and there was even banners in my room when I arrived last night, which was pretty impressive. As Mohammed just mentioned, I'm the author of the book, The Obesity Paradox, which is probably my disclosure that this book it's not much of a disclosure now because it was published over 4 years ago. But if any of you want to increase my conflict, just go on to Amazon.com or stop on your Barnes & Nobles, and you can still pick this up. Mohammed also mentioned that I'm editor-in-chief of Progress in Cardiovascular Diseases, and my very first issue when I took over the journal 4 years ago in January 2014 was on this topic of obesity and the obesity paradox. And it's been my most successful issue so far. And so we updated this issue with Francisco Ortega from Spain, and I did an issue in July and August of last year with 18 top articles from people around the world, experts in this area. And I was also very delighted that the editor-in-chief of JACC, Valentin Fuster, very famous, probably the most famous cardiologist in the world right now, invited me to lead this big promotional writing tour for JACC on healthy weight and obesity prevention. And this has most of the information that I'll be talking about today in my presentation. I think we all realize now that obesity has been an epidemic in the United States. 75% of adults in the United States are either overweight or obese. And right now, the obese percentage in the U.S. having a BMI over 30 is 39.6, almost 40%. And I think what's more scary is that the morbid, that's kind of a mean term, so now it's referred to as severe obesity, BMIs over 40, has now reached 7.7%. So 1 in 12, 1 in 13 of adults in the U.S. now have BMIs over 40. And if this trend continues, we may actually see a reversal in the steady increase in life expectancy that's been occurring in the United States for decades. Now, obesity has many adverse effects on the cardiovascular system. It increases insulin resistance, which leads to glucose intolerance, metabolic syndrome, and the leading contributor to type 2 diabetes. It raises blood pressure. Certainly there are people who are thin that have hypertension, but when you gain weight, the blood pressure almost always goes up. I've actually published a lot about the abnormal LV geometry that occurs. Certainly occurs with hypertension, but even independent of blood pressure, obesity leads to concentric remodeling and left ventricular hypertrophy. It also markedly worsens the lipids, particularly raising the triglycerides and decreasing the cardioprotective HDL particles. And it leads to abnormalities in endothelial function, which is probably the common denominator in all vascular diseases. It leads to systolic and particularly diastolic ventricular dysfunction because the adipocytes release cytokines that then stimulate the liver to produce proteins like C-reactive protein. Obesity is certainly associated with an inflammatory state and many other adverse effects that can impact cardiovascular disease. So it's no surprise then that almost all the cardiovascular diseases that we take care of, things like hypertension, heart failure, coronary heart disease, atrial fibrillation, are all markedly increased in the setting of obesity. Now, there's a lot of controversy on what is the major driver of obesity, and certainly what has gotten the most publicity is things like the sugary beverages, the fast foods, blaming it all on Coca-Cola, Pepsi-Cola, Taco Bell, Burger King, McDonald's. And certainly this all contributes. But my colleagues and I really believe the number one driver has really been the marked decline that occurs in physical activity during the last 5 decades. And we had this big paper come out a couple of years ago that got a lot of publicity. We measured 5-decade trends in household management energy expenditure, that in women. That's a fancy way of basically saying housework in women. And this, again, paper got a lot of publicity, and it wasn't all great publicity. And for what I mean, there was a picture of me in one of the major newspapers, and right next to my picture it said, "Women are getting fat because they're not doing enough housework." So you can imagine how well that went over on the home front. We were on Fox News 3 times in one night. I don't think any of you probably watch Fox News, but it's on every night in all the homes in Louisiana. We were on the Jay Leno, one of his last monologues, talking about this paper. My daughter, who was a medical student at the time, came home and told me that my sister, who was a social worker, was very upset about my paper. But what we basically showed in this paper that we measured for 5 decades of energy expenditure, we see very marked declines that are occurring over the 5 decades. And people realize this with industrialization. There's equipment now that doesn't require as much energy. But when we add it up, it was about 1,800 calories less per week now than 5 decades ago. Now, if you use the simple formula, about 100 calories are burned for each mile traveled by foot. That would mean that the typical woman today would have to be walking or jogging 18 more miles a week to make up for what's not being done in basically housework. So that's a lot of calories. And somebody asked me in one of the talk shows, did we study housework in men? And I said, are you kidding me? How would we possibly do that? It causes low testosterone, blindness, erectile dysfunction. Men don't do housework. But we did measure occupational physical activity in both men and women. And just like you'd expect, again, very marked declines in occupational physical activity. And when we plug this into what's happening to the obesity epidemic, the decline in occupational physical activity almost tracked exactly with the increased prevalence of obesity over the last 5 decades. And more recently, we studied the physical activity in mothers, and as you'd expect, in mothers, the sedentary time is increasing, the activity time is decreasing. This is even more noticeable in mothers who have very young children compared to older children. But in both mothers with young and older children, there's, again, very marked declines in the energy expenditure, about 1,800 calories per week. So again, a lot of reduction in physical activity. And not only does physical activity play a role in developing obesity in the mothers, but it also is, as we'll discuss later, probably the major contributor of fitness, or cardiorespiratory fitness, which is probably one of the most important prognostic factors. So this leads to reduction in fitness in the mothers. And there's also evidence that the hand who rocks the cradle rules the health of the next generation. And so this may also be playing a role in the future health of future weights and obesity in the children. Now, there's also debate about how much does obesity contribute to mortality. And this was a major meta-analysis that came out 6 years ago by Catherine Flegel at the time at the CDC. It was 97 studies, 2.9 million individuals, over 270,000 deaths, so a lot of statistical power. As you'd expect, they showed that relative to normal weight, obesity was associated with higher mortality. But it was all because of the class 2 and class 3 obesity, BMIs over 35 or over 40, whereas grade 1 obesity, which was a BMI over 30, between 30 and 34.9, was actually associated with a slight trend toward lower mortality, and the overweight in this paper, which is BMIs 25 to 30, actually had the lowest mortality, 6% lower than did the normal BMI. Now, this was criticized because maybe it didn't totally correct for smoking and lifetime smoking, and so smokers tend to be thinner, and that could have affected the results. But still, many other studies are suggesting some of the same findings. And in fact, in the older group, over 65, there was a non-significant trend of 10% higher mortality, but not statistically significant even in those with BMIs above 35. Now, there's no question, though, that obesity leads to more cardiovascular diseases. This is a major study that was in JAMA Cardiology last year of 10 analysis of 10 U.S. cohorts with 3.2 million years of follow-up, and basically showed that all cardiovascular diseases morbidity was significantly increased in the setting of obesity, but didn't show an increased mortality. And likewise, almost the same week, a paper came out from 300,000 white European in the European Heart Journal that showed that all cardiovascular diseases was increased in obesity with BMI, but even more so if they did things like waist circumference or waist to hip ratio. But again, the effect was stronger for cardiovascular morbidity, not necessarily for all-cause mortality. And then, despite the fact that, as I mentioned, obesity adversely impacts all of our risk factors and markedly increases the prevalence of cardiovascular diseases, the patients who I am taking care of in the office, and many of you are taking care of with cardiovascular diseases, things like hypertension, heart failure, and coronary heart disease, and end atrial fibrillation, have all had an obesity paradox, meaning that in the patients who have established cardiovascular disease, the overweight and obese are tending to have a better survival than are the thinner patients with those same diseases. And that's what we're going to discuss in a few minutes. This has been particularly noted for heart failure, and I reviewed this data in our Progress in Cardiovascular Diseases a few years ago. There's no question that overweight and obese develop way more heart failure. This is data from 15 years ago from Kankaya and colleagues and published in the New England Journal from the Framingham Heart Study, 5,881 Framingham participants, and showed pretty much a very strong increase in the prevalence of heart failure with increasing obesity. For every 1 kilogram per meter squared increase in BMI, the prevalence of heart failure increased 5% in men and 7% in women. And we know now that obesity particularly increases heart failure with preserved ejection fraction more so than heart failure with reduced ejection fraction. So our obese are having way more heart failure than the thin patients. But once they develop heart failure, this is probably the first report of this, almost 2 decades ago now, from Tamara Harwick here in California at UCLA. She and Greg Fonarow published this paper in JACC of 1,000 people with systolic heart failure. And in this paper, she showed that the best survival was in the overweight, followed closely by the obese, and the worst survival was the underweight, followed closely by the normal BMI patients. In this paper, she showed, again, almost 2 decades ago, that a higher BMI was an independent predictor statistically of better survival among systolic heart failure. And we actually took it a step further. We actually assessed in a paper years ago that I had a hard time getting published. In fact, it was rejected 7 times, and now it's been one of my most cited papers, cited almost 500 times in the literature. We actually assessed 300 patients with systolic heart failure. Not only did we assess their BMI, we actually measured percent body fat. And we showed in this paper that those who had the higher BMI, as well as the highest percent body fat, had the best survival, considerably better than those who had the lowest BMIs and lowest percent body fats. Now, you might say maybe the low patients are having cardiac cachexia. Well, this study was done in New Orleans, Louisiana, and I can tell you we don't have too much cachexia in New Orleans. Our homeless are not cachexic. In fact, the BMIs in the lowest quintile were averaging BMIs of 23 and percent body fats in the low 20s, so hardly cachectic. In this paper, we showed for every 1% increase in body fat, there was a 13% lower mortality, again, in systolic heart failure. So the reasons for this is surprising. It's hard to know. Certainly advanced heart failure is a catabolic state. Obese may have more metabolic reserve. The adipose tissue may produce things like TNF-alpha receptors that may neutralize TNF-alpha. Obese have lower expression of things like atrial natriuretic peptides and plasma renin activity that may be protective for them. They also have higher blood pressures, so that may allow them to tolerate the higher doses of our good cardiac medications that are producing survival benefits. The reasons are not totally clear, but this is something that we're seeing every day in our practices. And it's not just heart failure. Heart failure is probably the thing discovered first. In this paper, I reviewed all the data in coronary heart disease, atrial fibrillation, and other diseases. And we published a paper in the Mayo Clinic Proceedings 7 years ago where we assessed 581 patients with 3-year follow-up with coronary heart disease in our cardiac rehabilitation program. And we assessed not only BMI, but again, we assessed body fat. We defined low BMI as less than 25, so that's basically normal BMI. And we defined low percent body fat as less than 25% in men and less than 35% in women. And we showed in this paper that both low BMI and a low body fat were both associated with 2.5 to 3-fold higher mortality rates. And during the follow-up, almost all of our mortality was noted in those who had both a low BMI and a low body fat, 5 times higher mortality than any of the 3 other groups. And if we excluded the underweight, and there wasn't many, there was only 6 underweight patients with BMIs under 18.5 out of the 581, but if we excluded those, 3 of them died, but if we excluded those, the results were exactly the same. In another paper in JACC, we assessed 570 coronary patients where we not only measured their body fat, but we also measured their lean mass, which is really non-fat mass, but lean mass is mostly muscle mass. It also involves the skeleton. And we showed in this paper that both having a higher body fat, but also having a high lean mass were associated with better survival. Now, the lean mass is not surprising because it would make sense that having more muscle would be protective. And many studies now are showing that muscular strength is very important to protect against cardiovascular risk factors and cardiovascular diseases. But in this paper, we showed that the best survival was those who were the biggest of the big, both a high percent body fat and a high lean mass. The lowest survival or the highest death rate was in those who were the thinnest, the low body fat, but also the low lean mass. And if you had one of the two, you had an intermediate 3-year survival. So again, both high body fat and high lean mass appeared protective against mortality in our coronary heart disease patients. Now, fitness is also very important and involved in this. And this is a paper in my journal from Barry and colleagues that had analyzed 10 studies that were prospective and objectively measured both fitness and BMI. And so there's been a debate for years about fitness versus fatness and assessed their impact on all-cause mortality. And in this meta-analysis, they showed that compared to the normal weight fit, and fit was usually defined as not falling in the bottom quintile or the bottom quartile for fitness based on age and gender. So the normal weight fit, compared to them, the unfit, those who fell in the bottom level of fitness, basically had twice the mortality, regardless of what they weighed. Overweight fit and obese fit had similar survival as did the normal weight fit, and so they concluded from this analysis that fitness was actually more important than fatness for long-term survival. And we've assessed this in our heart patients too. In this study of 10,000 coronary heart disease patients followed for over 15 years, we measured fitness on the treadmill and defined the fitness based on estimated METs, speed and incline of the treadmill, and then you get the estimated METs, which is used in every treadmill test across the world every day, that those who fell in the bottom tertile for age and gender associated fitness were defined as those who were unfit. And we showed in this paper that if you were fit, and this is, again, not super fit, this just means that you didn't fall into the bottom tertile for age and gender, you basically had a good survival regardless of your BMI, your waist circumference, and your percent body fat. Whereas if you were unfit, falling in the bottom tertile of fitness, then there was an your mortality was much higher, but there was an obesity paradox. Among the unfit, those who were heavier, higher BMI, higher waist circumference, higher percent body fat, actually did better than did the unfit patients who were thinner. And this is for all-cause mortality, and we basically showed almost the exact same findings for cardiovascular mortality. So this is coronary heart disease, and I recently showed this in the Mayo Clinic proceedings for systolic heart failure. In a study of 2,066 patients with systolic heart failure, ejection fractions averaging 30%, followed for 3 years, we actually measured their fitness precisely by a cardiopulmonary stress test with gas exchange. And we defined fit as having a peak VO2 greater than 14 cc's of oxygen per kilogram per minute. And I don't know how many of you work with peak oxygen consumption, but if any of you do, you know that having a peak VO2 of 14 is no super level of fitness. Many of you wouldn't be too happy if your peak VO2 was only 14, but that's been the number that's been used for 3 decades in heart failure since Donna Mancini did her first papers on this 3 decades ago, and this was been used for decades to even list people for cardiac transplantation. And we showed in this paper that if you were fit with systolic heart failure, having a peak VO2 above 14, you basically had a pretty good survival. And it didn't matter what your BMI was, whether you were an obese, overweight, or the normal weight. We had already excluded the underweight because we know that they always have the higher mortality. So if you're fit, you had a good survival. Whereas if you were unfit, having a peak VO2 under 14, you had a much higher mortality, and there was a obesity paradox. With among the unfit, the obese did better than the overweight, and the worst survival was in the normal BMI unfit patients with systolic heart failure. So both in coronary disease and heart failure, we are showing that fitness markedly alters the relationship between adiposity and subsequent survival. In a paper where I joined together with colleagues from Norway in the Hunt study that we published last year, a year and a half ago in the American Journal of Medicine, 6,500 coronary patients we measured during a 15-year follow-up. We measured both their physical activity and their BMI. And we showed that physical activity was a much better predictor of survival than was BMI. And once you corrected for physical activity, BMI actually no longer remained a significant contributor of survival. And in a JACC paper last year that got a lot of publicity, 3,500 patients from Norway who followed for over 15 years, we actually measured changes in physical activity and changes in BMI over time. And we showed in this paper that those who either maintained a high physical activity or increased their physical activity had excellent cardiovascular and all-cause survival. Whereas after you corrected for physical activity, BMI, changes in BMI, including weight loss, were not statistically related to survival, again suggesting that the physical activity was more important than the weight. Now, there's also been a lot of talk about the metabolically healthy obesity. Metabolically healthy obese means that the obese who don't have high sugar, don't have bad lipids, don't have elevated blood pressure, these would be considered metabolically healthy. And years ago, it was said that these patients are doing very well from a prognosis standpoint. And more recent papers are questioning this because, one, they're showing that if you follow the metabolically healthy long enough, you find that over time, they lose their metabolic healthiness. When they gain more weight, the lipids, the blood pressure, the sugars tend to go up. Second is that there's papers that are showing that even among the metabolically healthy obese, they still are having increased cardiovascular disease, particularly increased heart failure. Only a little bit increases in the other cardiovascular diseases, but heart failure is still particularly increased. But these papers are showing, though, that metabolic unhealthiness is even worse than the weight. Because among the thin patients who have metabolically unhealthiness, meaning elevated sugars, blood pressure, and lipids, they actually are worse than the obese who are metabolically healthy. So again, metabolic unhealthiness, which is more common among the obese, is even worse than obesity per se. And we pointed out in several editorials in JACC and one recently in the Lancet Diabetes Endocrinology that one thing that's missing in all these studies is that they didn't really assess physical activity and fitness. And we just had a paper come out that showed that in those papers that did assess physical activity and fitness, that once that was considered, those who were metabolically healthy, obese, and who had high physical activity or high fitness, they really did have a very excellent prognosis, at least with regard to survival and cardiovascular survival over time. Now, it also matters what the age is, because if you look at young people, pretty much across the board that the higher weights are associated with worse survival. But if you start looking at older people with the typical patients that we have in our practices over the age of 60 years old, you really do start seeing a U-shaped curve between BMI and subsequent survival, with the higher mortalities at the low ends and the high ends of the curve, and a sweet spot in the middle that's probably in the range of the upper 20s as the perfect BMI. And I think that, again, that this is just looking at BMI independently. If you factored fitness into the equation, things may look a lot different. Now, there's no question, though, that physical activity, it's well known that it's associated with very significant contributors to longevity. And this is a famous paper that came out in the Lancet by Wen and colleagues of 400,000 people from Taiwan, published in Lancet 7 years ago. And this got a lot of publicity, particularly when this paper came out. They showed that one only had to do 10 or 15 minutes of physical activity to get survival benefits. So that made the headlines. People loved to hear that they only had to do 10 to 15 minutes. But it had a lot of other things, and I'm going to get back to this paper at the end of the talk as well. But one of the things that it particularly shows as well is that at younger ages, it didn't matter that much. But once you started hitting about age 60, there was a big difference between those with higher versus lower physical activity with regard to subsequent survival. So in our patients that we're seeing in our practices, the physical activity is so certainly associated with survival. Now, probably even more important than physical activity is cardiorespiratory fitness. How long can one do on a treadmill test? How fast can someone walk? How fast can someone jog? So the more fit people are, they certainly have better survival. And one of the major contributors of fitness, of course, is physical activity. But it's not the only contributor, because there is some natural, genetic component of fitness as well. Some people are just naturally more athletic, more fit than others who may be exercising even more than they are. And previous studies used to say that once you got up to about 10 METs, METs is the common way clinically we typically grade fitness on treadmill tests. Once you got up to about 10 METs, you had maximized out your fitness. But now studies are even showing going 13, 15, 17, 18, 20 METs that you get progressive improvements in fitness with improvements in survival as you get fitter and fitter. Although if you notice that the slope of the curve is going to be much less, so certainly the biggest bang for the buck is getting people out of the low fitness category into more moderate fitness categories where there's a much bigger benefit for each increment increase in the fitness. And this is a big meta-analysis on fitness that was published a decade ago in JAMA by Kodama and colleagues, 33 studies over 100,000 individuals, where he basically showed that for every 1 MET change in cardiorespiratory fitness, mortality and cardiovascular disease, coronary heart disease events were affected by 13 and 15% respectively. So very dramatic changes that are associated with each increment in metabolic equivalent or each increment in improvement in fitness. And these are quotes that have been said for years. Cicero said, exercise and temperance can preserve something of our strength in old age. Socrates said, it is not bodily habit spoiled by rest and illness, but preserved for a long time by motion and exercise. The Earl of Derby said, those who think they have not time for bodily exercise will sooner or later have to find time for illness. And the famous clinician, Paul Dudley White, said, healthy exercise is valuable not only for the maintenance of good physiologic functions of the body, but also mental clarity and a feeling of good health. So if this is all true, then why do we keep hearing the warning that before beginning an exercise program, see your clinician? It seems to me that we should have this warning before beginning a program of sedentary living in isolation, you probably should see your physician. Now, the benefits of physical activity, exercise, and cardiorespiratory fitness are multiple. Effects on heart rate variability of sympathetic, parasympathetic tone, reducing blood pressure, improving endothelial function, improving the platelets, improving blood viscosity, getting increasing mitochondrial density, reducing inflammation, improving insulin sensitivity. Multiple benefits. But one that I really believe that it's extremely important and I think has been neglected in a lot of medicine is the effects on psychological risk factors. This is, I think, true in all of medicine, but also has been neglected in cardiovascular diseases. And so psychosocial stress is an important cardiovascular risk factor that impacts the recovery, not impacts development of cardiovascular diseases in the first place, but also impacts the recovery of our patients with cardiovascular diseases. And as Cicero said, it is exercise alone that supports the spirit and keeps the mind in vigor. This is a paper that we did a couple of years ago and published in the Canadian Journal of Cardiology, reviewing all the data from cardiac rehabilitation programs. Many of it was from our own data that we had published over decades on the impact of exercise training and specifically cardiac rehabilitation on improvements in psychologic stress and psychologic stress-induced increased mortality rates. And in a paper in the Archives of Internal Medicine a decade ago, we showed that we'd use validated questionnaires to measure several psychological risk factors, anxiety, hostility, and depression. And as you can see, many of our patients with coronary heart disease who are entering cardiac rehab have a lot of psychological stress, particularly the younger patients, more so, and we define younger in this paper as under 55 and older as above 70. But the older people have psychological stress too, but it was way higher anxiety rates in the patients, in the younger patients than in the older. But following cardiac rehabilitation, there were dramatic declines, probably more meaningful declines in the younger patients who had such a high prevalence of anxiety to begin with. For hostility, which is another way of saying unexpressed anger, again, way higher in the younger patients than the older, but both groups got greater than 50% reductions following cardiac rehabilitation. And probably the thing that's the most important, that gets the most publicity, is the depression. And depression was only a little bit higher in the younger patients because the older patients with coronary heart disease also had a very high prevalence of depression. But following cardiac rehabilitation and exercise training program, the younger patients got almost 80% improvements in the depression, and the younger patients got 67% reductions in their depression. So dramatic improvements following a formal cardiac rehabilitation and exercise training program. And the reason why this is important, this is a paper that we published in the American Journal of Medicine a decade ago. We showed that the depressed coronary patients have 4 to 5 times higher mortality during the next 3 years than do the patients who don't meet criteria for depression. And the controlled depressed, we define controlled depressed as those who were candidates to enter cardiac rehabilitation but didn't enter the program, but did the testing for psychological stress. And those who were depressed had over 3 times higher mortality rates than were the depressed patients who completed a cardiac rehabilitation and exercise training program. Now, many of you who work with cardiac rehabilitation know that cardiac rehab is more than just exercise. It's a lot of tender loving care. It's a lot of attention directed to patients by the dietitian, the exercise physiologist, the cardiac rehabilitation nurse, as well as by the clinicians. So we tried to determine, was it the exercise or was it the improvement in exercise capacity to be the driver. And we actually did this with cardiopulmonary stress testing, and we showed in this paper that those who did not improve their peak VO2, those who had the same or even lower values of peak VO2 following cardiac rehabilitation. In a recent paper, we showed, unfortunately, that 23% of our patients in cardiac rehab are not improving their peak VO2. And these patients continue to have high prevalence of depression and high mortality. Whereas those who just get a little bit improvement or get a whole lot of improvement, both groups are dramatically reducing their prevalence of depression and their depression-related increased mortality, suggesting that if we could just get a small improvement in exercise capacity, that's what's really needed to reduce psychological stress and to reduce the mortality associated with it. Now, there's always questions about how much exercise should one be doing. And back to this Wen paper that I showed you earlier, the 400,000 from Taiwan, they showed in this paper that, again, the headlines were just those who only did 15 minutes of exercise per day were getting already mortality benefits. But they also showed in this paper the more and more moderate exercise that one did, the better was the survival, up to about an hour. At about an hour, the line starts leveling off. But with vigorous exercise, and they defined vigorous as only about 6 to 7 METs. So that's basically a slow jog, a really fast walk. It's not super vigorous. It's not like doing marathon running type exercise or hard exercise training. But at 6 to 7 METs of exercise, they showed that the line started to level off after only about 30 minutes, suggesting that the more and more you did, you didn't continue to get additional benefit. And so this goes in line with a big running study that we published in JACC a few years ago of 55,000 people. We compared 13,000 runners with 42,000 non-runners during a 15-year follow-up. And we showed in this paper, not so surprisingly, that the runners had a 30% lower mortality and a 45% lower cardiovascular mortality. Now, that's not a major surprise because I think most people would think that running would be good and would probably improve one's risk. Also, those who are capable of running may be a little bit different than those not capable of running or not doing the running, maybe because of selection bias. So again, not totally a surprise. We showed also that those who were persistent runners during the course of the study got the most benefit. Those who started running but stopped, or those who weren't running but started, had half the benefit compared to those who were never runners. We also showed in this paper the more and more the fitness went up, The more you ran, the more the fitness went up, and generally fitness is associated with better survival. Higher fitness is lower events, and the more you ran, the higher your fitness was. But what was a surprise was when we looked at the running doses, and we divided the 13,000 runners into different doses, quintile 1 through quintile 5. We showed that those runners who were in quintile 1, the lowest dose runners, and for times per week, these are people who are running only 1 to 2 times per week, people who are running less than 6 miles per week, people who are running less than 51 minutes per week. These quintile 1 runners got the same benefit on both cardiovascular and all-cause mortality as did those who were in the higher doses. Same as quintiles 2, 3, and 4, and a slight trend toward better survival than those in quintile 5. And in a subsequent paper, we took the quintile 5s and divided them into tertiles and basically showed that the very highest runners, those who are in the top 8% of running doses, actually appeared to lose the benefit. Again, not compared to non-runners, but compared to those who were doing lower doses in running. Certainly suggesting that more and more was not better, but even raising the possibility that doing more and more could actually be worse. Now, in a recent study, I teamed together with the Copenhagen group who assessed 8,500 individuals in their Copenhagen City Heart Study during 25-year follow-up and looked at leisure time physical activities. And it was nice that almost all the leisure time physical activities, whether it's health club, jogging, swimming, cycling, soccer, badminton, tennis, all of them were associated with better survival. What we thought was also interesting, though, was that some were associated with better survival than others, like tennis, badminton. It may have something to do with hand-eye coordination and not just exercise, but some athletic ability. It could also be maybe that sports that have more social interaction could be doing better than those sports that people tend to do by themselves. And again, it could also be other factors that we didn't have data on, like, for example, socioeconomic and education level. Maybe those things are more associated with better survival, and maybe those are the people who are doing more tennis and badminton than some of the other sports. But still, again, I think overall interesting results. And more recently, I've teamed with the people from Norway with something called PAI, a personalized activity intelligence, which basically measures the heart rate throughout the day, and you get more points if your heart rate goes up more. And basically we showed in a study of 40,000 individuals that those who got high amounts of PAI, which means that they got more times that they met high heart rates, that getting higher heart rates during exercise is producing more benefit than with lower heart rates. So meaning that the high intensity exercise, like running, where the heart rate tends to go up, may be producing more benefits than just really slow exercise. But certainly all exercise is better than no exercise. And I think it does depend on what one's goal is. Is it for health or is it for sports performance? And this is a big study that was done in the Mayo Clinic proceedings by Paul Thompson and Paul Williams, that was done of 2,400 myocardial infarction survivors. And they measured the physical activity during over 10-year follow-up and showed that those who were more physically active, again, the people after a myocardial infarction, those who were more physically active progressively lowered their mortality, lowered their cardiovascular mortality, up to a point, up to about 7.2 met hours per day walked or run, which is the equivalent of about 30 miles of running and 46 miles of walking. At that point, these individuals appeared to lose the benefit. Again, not compared to non-exercises, but compared to those who were doing lower amounts of exercise. Now, there's nothing magically happens at mile 30. You know, that if somebody's running 29.5 miles a week and they're getting all the benefit, and then they run one extra mile, and then they don't get the benefit. But the point is, again here, that doing more and more and more may not be given extra benefit and could actually be associated with some loss in benefit. So there may be a sweet spot. Ooh, I don't know what happened to that one. So as Hippocrates said centuries ago, there may be something to this moderation. If we could give every individual the right amount of nourishment and exercise, not too little, but also not too much, we would have found the safest way to help. And I do think that the problem in our society is not too much exercise. So that's a few of our individuals who are maybe pushing it to the limit, but certainly the problem is lack of physical activity and lack of exercise. And we all have to do a better job of promoting it throughout the healthcare system. We should be doing this with every patient, every visit, finding out are they exercising, just like we do with smoking, finding out what is their physical activity, are they exercising, and encouraging them to do more and at least do something, to do some movement every day, and probably for the majority of people to be doing 150 minutes per week of moderate or vigorous physical activity, as are the guidelines that were recently published by the Federal Physical Activity Guidelines last year. So in summary and conclusions, I do think there's overwhelming evidence that supports the importance of obesity in the pathogenesis and progression of most cardiovascular diseases. And I think sometimes when you hear what I was saying before about the obesity paradox in our patients with cardiovascular disease, some people get the impression that I was saying that it's better to be fatter, and that's not, please don't quote me like that, that in a perfect world, everyone would remain lean and fit throughout the lifespan. But that's hardly what's happening. People are gaining weight and losing fitness with age. And there's an obesity paradox in our patients that we're seeing every day in cardiovascular disease. At present, I think there's actually pretty little evidence supporting purposeful weight reduction, but substantial on increasing physical activity and exercise training, especially that increases the cardiorespiratory fitness, or the METs. If the current obesity epidemic continues, however, particularly scary is what's happening with the kids and what's happening to the, not just general overweightness and obesity, but what's happening to the extreme ends of severe obesity. I think that if this trend continues, it's not going to be good for our society in the upcoming decades. Both fitness and fatness are important, and in a perfect world, as I mentioned, everyone will remain lean and fit throughout the lifespan from childhood to old age. But this is hardly the case where people are gaining weight and losing fitness. So if you did one of the two, it would be better to gain some weight and maintain fitness than vice versa, as fitness appears to be considerably more important than fatness for long-term health. And finally, this is the kind of thing I think we hear as clinicians every day. Give it to me straight, doc. How long do I have to completely ignore your advice? They may not say it exactly like that, but that's kind of what we end up hearing. And the reason why everybody's saying they're not exercising, it's not the slide's not advancing here. Can you advance it? I don't know if it might be this. Go back one. The reason why everyone's saying that, advance it one now. The reason why everyone says they're not exercising is they don't have time. You know, that's everyone's excuse, and many of you probably feel the same. So the answer to that is what fits your busy schedule better, exercising so many minutes per day or being dead 24 hours a day. Next, and again, thank you very much for your attention, and thank you, Mohammed, for the invitation to speak here.